Why the necessity for toric IOLs? We know that toric IOLs have been around for more than 1.5 decades now, but many surgeons are using toric IOLs, but there is still a lot of hesitancy among the young surgeons or even intermediate level surgeons to take up toric IOLs. So I'll briefly go through why do we need to take up toric IOLs. So now we know that with phacoemulsification and better surgical techniques and smaller incisions, we have a better predictability of the post-operative refraction that will come for the patient. So, and also with better biometry and better IOLs, cataract surgery has become a refractive surgery. Hence, we need to give the best that we can to the patient. So astigmatism prevalence in cataract surgery, as we all know, it is almost approximately 50% of your cataract surgery patients will have one diopter or more of pre-existing corneal astigmatism. So these are the patients who will benefit from a toric IOL. So we need to address this issue. So as we all know that a vision with even a small amount of cylinder will not be as crisp as without astigmatism. So your daytime vision and also the nighttime vision will be slightly distorted or blurred when there is little amount of astigmatism remaining. So toric IOLs were introduced by Shimizu et al. In 1992 as a rigid 3-piece lens, and it underwent a lot of modifications as to what we have today. So we all know that it is the acrylic hydrophobic platform which is used to place the toricity, because these are known for their stability, because they adhere to the capsule, and a profound shrink wrap effect occurs which keeps the IOL locked in place for years. So what the notification used? How do we describe the toricity? So basically when you see these numbers, you'll get confused. Different lenses have different notations. So it is basically to describe the power which is there on the IOL, how it will translate to the power which will reflect it on the cornea. So it is obviously going to be lesser. So now we know that all the premium IOLs which are also available in the toric platform, because as we are promising the patient a better vision, we need to take care of these small to moderate or even high astigmatism that the patient may be suffering from. So advanced monofocals, the multifocals, trifocals, EDOFs, most of the lenses also have the toric platform on them. Now, which are the cases that we will go for a toric IOL? So most important thing that we need to remember is it is the pre-existing regular corneal astigmatism, more than 0.75 or 1 diopter, that can be addressed. Now, situations like glaucoma, epiretinal membrane, macular degeneration and other pathologies will also benefit. They are not contraindications for toric IOL. The only place where it may be contraindicated, as we know, is irregular corneas, or those patients who have so much of irregularity that they need RGP or scleral contact lenses to regularize the surface. There, the toric IOLs will not benefit. So how do you go about? Now, when you're planning your early toric cases, you're doing fairly good, you're getting consistently good results with your monofocal IOLs, your biometry is well adjusted, you're happy with your results. Now you need to step up and you want to promise something more to your patients. So how will you begin? So first, most important thing to remember is it is the regular astigmatism. So as we know, it is the angle between the two principal meridians when they are perpendicular. So with the rule, against the rule, oblique and bioblique, that is the definition. So here we are dealing with regular astigmatism. With the rule means your steep axis is going to be vertical, and against the rule means the steep axis is horizontal. These are the two criteria which you need to remember. Now, which patient to choose? Now, when you're going through the biometry of the patient, just keep an eye on the keratometry readings. Is there a significant astigmatism? Is it very small? Is it significant that where you can implant a toric IOL? So choose a patient initially who will be a little more forgiving, maybe around 1 to 2 diopters of astigmatism. Explain the additional benefit that the patient may get. Don't overpromise that it will be bang on 0-0 refraction, but try to deliver on target. Very important to remember that before you do your biometry, the surface needs to be good. There shouldn't be any severe dry eye, meibomian gland dysfunction. If there's a pterygium, you need to deal with that before you plan a toric IOL, because these problems will give you unreliable and inaccurate readings. So you stabilize the surface and you repeat the readings. And if there's confusion, then compare your biometry and topography readings as well. Another concept to remember is the axis notation. So here it starts from the left eye laterally, that will be 0 to 180, and then in the right eye it will be nasally starting 0 to 180. Coming to biometry, so it is the corneal keratometric astigmatism we are going to deal with and not the total refractive astigmatism. So keratometry, you always try to use two instruments. Either use your auto-K instrument, the biometer, or a tomographer. Now the OCT-based systems like IOL 700 and Antiron will also give you the K readings. Important concept to remember here is the posterior corneal astigmatism to be taken into consideration. So when you're doing the keratometry, it is giving you only the anterior curvature. But the posterior corneal curvature also plays a role in the total corneal astigmatism that is there. So Dr. Douglas Koch found out that the effect of the posterior corneal astigmatism, it is in the vertical meridian. The posterior steepest meridian will almost always be vertically aligned. So that will give you an error while you are calculating. With the rule group, the overcorrection will be almost of 0.5 diopters, and against the rule, there will be an undercorrection of 0.3 diopters. So the machine should be able to calculate for the same. Now, coming to another important concept which everybody of us is scared of is there is some surgically induced astigmatism. Now, how to incorporate that, what to do. So drhill.com gave a surgically induced astigmatism calculator to calculate your SIA, which was initially based on the median value, so where you input your own data of around 30 to 50 patients, how much ever you can, and that will give you a median value of what is your overall SIA for your right eye separately and your left eye separately. Then it also came to the centroid values, which is actually a little simpler to understand. So the software also gives you the centroid value of your SIA. Now what is SIA? It is basically the flattening effect that will come because of your incision. So it is a vector which is composed not only of the flattening steepening effect but also the torque. So mathematically it becomes a little more daunting to the surgeon as to what is exactly happening. So what happened is Dr. Hill observed that, if you're going with a temporal clear corneal incision, then and you use a centroid value which between 0.08 to 0.14, then most of the surgeons are falling in that group. So what he suggested is that if you have not gone ahead and calculated your own SIA, then you could use a mean centroid value of 0.12 while using the Toric calculators. And he suggests that using the temporal clear corneal incision. Now coming to the biometry that we use for the eye power calculation, optical biometer is the best, but in some situations where you cannot use the optical biometer, it is better to use the immersion over the contact one. Now calculating the spherical component is the one of the crux things that we need to do. So we know that the newer generation formulas like Olsen and Barrett's Universal 2, which are incorporated in most of the newer optical biometers, they'll give us a good spherical power of the lens. Then the toric IOL power calculation, if you're using an optical biometer, something like Lenstar 900, IOL 700, Anterion, OA then we know that they have these calculators embedded on the system itself, and best of the IOL power formula will be used, and you will be able to get your IOL power with the toricity. But if you're not having these optical biometers, then you can even go online, use the Alcon online calculators, or Biotech online calculators, or the ASCRS Barrett's online calculator, or the Assort, and the other examples. So this is an example of the Lenstar 900 and the IOL 700 about, it gives you all the values of what is the corneal measurements that you have, and it gives you the suggested lenses and the toricity that you can use, at what axis you can implant them, and what is the residual astigmatism that will remain. Just sharing an example of the Barrett's Toric calculator. So this is a free online software that is available. You just have to enter your data, the patient's name, age, the lens that you want to use, the lens factor, and you have to give the flat K, the axis, the steep K, put the axis, the axial length, all the parameters that you have that needs to be, that will add to the accuracy of the IOL power that it calculates, and then it will give you the IOL power as well as the steep axis where you need to implant the IOL. Another is the Assort software, but it is not a free software, you need to pay for it. Again, based on similar principles, and it uses multiple IOL formulas, and it gives you the vectors in which your incision and the IOL will act. Among the Indian platform, you have the ICRIL Toric, that biotech example that I would like to share. Similarly, you can input your data and it will give you the examples in such a format. It is important that on these IOL calculators you note that the posterior corneal astigmatism is taken into consideration when the software is calculating your IOL. So it usually gives you 3 options which will correct your astigmatism to the best level. You need to see that the residual astigmatism should be minimal. Like if you see in option 1, the residual astigmatism is 0.27 at 178, which is still remaining against the rule. In option 2, if you see, the residual astigmatism remaining is 0.24 diopters at 88. So it is going vertically steep. So it is going slightly to the with the rule astigmatism, which is a preferable thing to do. So in this option, in this case, I would go for option 2 IOL in this case. So, like the example I was saying, it is better to keep the patient with the rule, the smallest residual with the rule astigmatism would be better while choosing which IOL needs to be implanted.